now let's hand over to Markus Walther, who, well, is usually also a busy clinician, but we are lucky that there are no emergency cases. But we know each other also for a long time. The initial starting point was actually barefoot running or minimal footwear running, but now we had many other interactions, and I'm very glad now to see you speaking now about your experience in your clinic in the middle of Munich in times of Corona.
Yeah, thanks a lot for the invitation to share our experience on orthopedic surgery here in times of Corona. The presentation is working?
Yes, it is.
Yes, okay, perfect. So, whenever we want to talk about elective surgery, or especially orthopedic surgeries in the time of the pandemic, we should step a little bit back to March 2020. And in March 2020, we had a really strange situation. We saw the pandemic going on in Italy, in France, seeing overcrowded hospitals. Here in Germany, it was still pretty calm, and then the healthcare authorities approached our hospitals and said, we have to expect about 20 to 50% of our population sick. There will be probably 1/3 of the population will go to die, and you have to prepare your hospital for this catastrophe. So that was the information we started with when I was called into the crisis staff here in Munich. And then we started to prepare our orthopedic hospital for the catastrophe, which was really a crazy thing. I never thought that I had to do that during my working time. So we started to give training for orthopedic surgeons in ventilation therapy and ICU management, because the orthopedic surgeon normally doesn't do that. And then we saw that there's a huge need for ventilation, and in an orthopedic hospital, normally the ICU is very small. So we thought, what can we do to increase our capacity? And then we worked on plans to modify our multiple ORs in huge ICU units that we could place about 8 ventilation patients per OR, because in our OR we have the oxygen you need to make the ventilation therapy. And the third thing was we tried to get hold of any protection devices available, because we saw in the pictures from Italy, they had to treat the COVID patients without any gloves, without any protection devices. And the staff here was really scared. The major problem is that medical staff is not like politicians. The politicians assume that every doctor can treat COVID, every nurse can treat COVID, and every hospital bed is suitable for the treatment of COVID patients. And in politics, you have that situation. One politician makes finances, and then 2 years later, defense, and then another 2 years later, social affairs. But the training in medicine is very specific, and it's nearly impossible to treat as an orthopedic surgeon such complex ventilation problems. And so this nice cartoon came across my desk where they said, stay at home if you don't want an orthopedic surgeon treating your pneumonia. And there's a lot of truth behind that. And the other thing, what the politicians made really strange, they shut down the whole healthcare system, and they didn't care at all what it was about and if this unit is really suitable to treat COVID. So they shut down rehabilitation centers, they shut down psychosomatic hospitals, and well, we had a lot of capacity, but the triage, which was in the media a lot, in Germany, it was not between the COVID patients for ventilation, but it was between COVID patients and all the others having severe medical issues like cancer, heart attacks, and stroke. And we had a dramatically increased number of deaths with cancer, heart attacks, and stroke, because all the hospitals have been blocked for COVID. We started a network together with 2 other private hospitals here in southern Munich. It was the Orthopedic Klinik Munich South. They are focused on general and trauma surgery. And the internal medicine hospital in Munich South, they had their focus on internal medicine, including pulmonary diseases. So every really severe COVID patients went to them. And our focus was the treatment of musculoskeletal diseases, because our ICU capacity was very limited, and we only took over COVID patients for rehabilitation, or if the others were really full. In our hospital, the major problem was, well, the staff was scared, so we wanted to prevent our staff from getting infected. And we needed to to prevent our patients from getting infected, because getting infected during any kind of medical treatment makes the whole thing very dangerous. And we have a huge outpatient clinic with about 2,000 to 3,000 patients a day. And it was really mandatory to identify infected patients and get them as safe as possible through the treatment process and to separate them from the others. And the problem was really, to make good decisions without any data or information. So what we did to prevent our staff from getting affected? Well, we introduced these general COVID rules like distance, short contact, reduction of contacts, following the general hygienic rules, which should be managed in hospital anyway. And we try to get hold of masks, that everybody can wear a mask during his work, which is normally not done in all wards in the hospital. So what did we do for distance, for example? Well, we started to define a maximum persons per room. You see on the picture here on the right, the bottom, where it said only 2 persons are allowed in this room at any time. So to give enough space and to reduce the contact time. Then we were really lucky to get a lot of personal protection equipment. You see us here in the equipment we normally use if we are not sure if a patient is suffering from COVID or not. And we made regulations that all team meetings are limited to a maximum of 15 minutes. The same is for patient contacts in the outpatient clinic. For the staff, we started with a 2-shift model that we have 2 teams, and the 2 teams try to avoid to meet each other. And we started a no dispensable people in the hospital policy, which means no visitors, no industry, no visiting doctors, no accompanying persons, and a major entrance with ID control to prevent anybody from getting in who is not needed. And we reduced our outpatient clinics to 2 patients per hour per doctor. Normally we are about 4 patients per hour and per doctor. And we started a very tight test strategy depending on the exposure risk. For example, doctors working in the emergency unit, they are tested twice a week, outpatient clinic once a week. And if you only deal with tested patients which are very likely not infected, then you are tested every 2nd week. This is our temperature check. The temperature camera, that's me making a photograph of myself with the smartphone. And it shows the temperature of the people entering the hospital and allows to check if anybody has raised the temperature, and then the security staff would arrest those people for further investigation. To reduce patient contact, we started video outpatient clinics. That was a real step forward into digitalization in healthcare. Within 3 months after the start of COVID, about 50 providers entered this market. And our conclusion after 12 months, it works. It's very time consuming. It's easier to plan because the expectations of the patients are different. If they see you on video in the hospital, they expect you have everybody available at once. And if you have them at video, they accept that they have to come to see the anesthetist, for example, if no anesthetist is available at this time. The problem here, and that will limit video outpatient clinic at least for the next couple of months, the reimbursement is much lower compared to real outpatient clinic. So everybody you can get into the hospital, it makes more sense to see him directly, besides the fact that I think the medicine you can do is better if you can really examine the patient. There's some interesting facts from healthcare workers. Overall, the death rates in healthcare workers after infection is more or less the same as in the general population. But interestingly, those who the rationale behind that is that those dealing with
Markus,
yeah.
So at least I've missed the last 10 seconds or 15 seconds. There was some kind of a break.
Okay, so it's working again?
Yep. Mm-hmm.
Okay, yeah. I said there are some interesting facts from healthcare workers. In general, the death rates are more or less the same as in the general population, but they are low infection rates in people, doctors treating COVID patients, because they are so aware of the risk that they are very careful. And at the end, the death rate in the COVID treating population in the hospital is lower than in the others. So really interesting observation. The problem for the patient is if you get a general anesthesia while you're infected with COVID, you have a risk to die between 10 and 50%. And this is incredibly high for elective surgery. And the risk for pulmonary complications is higher than 50%. So this is really dangerous, and you really should only treat or operate on patients while they have COVID if it's a real emergency. Otherwise, you should wait until they are fine again. If you need to treat those patients, whenever possible, make regional anesthesia. That's not as risky as general anesthesia, and work with well-trained teams to have a short OR time and a short risk for any abnormal processes. So what's our test strategy for patients? Well, if a patient wants to be admitted for elective surgery, he needs a negative PCR test within the last 48 hours. Otherwise, he goes to an isolation ward if he is positive, or for clearing ward if the status is unclear. Meanwhile, we have also those antigen testing where you get the result within 15 minutes. And in the situation with a low incidence, you can work with those until you have the final PCR test. But the PCR is still the gold standard for testing. And as long as we have no PCR test, the patient is treated like he is COVID positive. The problem with the testing is are the false positive values. If you have a test specificity here, like in this picture of 99%, and you have this situation with 2 positives within 100, you have 1 false positive and 1 true positive. If you have more positive patients, about 10%, then you have much more positive results. And the problem in the hospital is if you have a lot of false negative results, the awareness goes down a lot to handle the positive patients, because it's very likely that's a false positive value. So that is always a challenge to keep the awareness within your staff. Just to show you a little bit the testing, you know, the PCR works very early and is very sensitive. The antigen tests is a little bit later. And so you have this gap here where you have a positive PCR, but still a negative antigen test. The antigen test is very helpful to detect patients, for example, if they have a flu, if they are COVID positive, or if they have just a normal flu. And just to show you how difficult it is with this testing, this guy here explains it.
So unfortunately, we can't hear this. Is this on purpose?
Oh. Okay.
Well,
sorry, then it doesn't transmit the sound from the video. Okay, yeah. Then I skipped that. It was very funny because Trump explained the testing systematic, and when it's positive and negative, and yeah, it's really nice. You should watch that on YouTube. So that was the situation during the last year, and since fall we have the second wave with a lot of symptomatic people and a quite high death rate. The current status for us is that we have about 90% capacity for orthopedic and trauma surgery. Yeah, it's not COVID, I'm vaccinated, so don't be scared. And there are two major factors for these limitations. This limitation is one, because we need capacity for this isolation ward and for this cleaning ward, and that limits our beds. And there's still a lower demand for elective orthopedic surgery. One group are the elderly patients, and they hope to be vaccinated and then have their procedures in a safer setting. For example, total hip replacement, total knee replacement, that's a typical population between 60 and 80 years. And we have a much lower incidence for trauma because we have less traffic on the street and we have less sports activities. All the ski resorts are closed, no soccer besides Premier League and only other professional sports, but the general sports, it's completely closed. So what we have learned after 1 year of pandemic within the orthopedic hospital, it seems that our current safety concept works pretty well. Within the last 6 months, we had only 2 transmissions between staff members, and they got infected while violating rules. They didn't wear the masks, and they stayed the whole day in a very small office, and that was definitely against the regulations. Currently, the spread of the virus here in our environment is mainly a problem in the private environment and maybe public traffic, but the hospital is really pretty safe because everybody is tested and most of the staff is already vaccinated. We really expect that this COVID virus will accompany us for the next years, and all the manufacturers are already researching for new vaccinations. And I expect we will have it like flu, that at the end of the year, you get your vaccination for flu together with COVID. A problem in the hospital is the high rate of vaccine skeptic. We have about 30 to 40% who don't want to be vaccinated because they are scared of the side effects, which is not really rational, but maybe that will change if you are only allowed to enter an airplane if you're vaccinated, but we will see. Yeah, and we are looking forward to the challenges with the new mutations, and nobody knows exactly how it will be and how dangerous those will be in the long run, but I hope we can catch up with our vaccination plans. Thank you very much.
Okay, Markus, thanks a lot. Well, for showing us these data and sharing this experience. So I think it's really remarkable. I mean, to have the responsibility for so many staff members and the patients, and it's in principle, as you really made clear, in the early days it was completely unclear where this is going towards to, and being confronted with as a physician to train rules for triage is not nice. But I think this has never happened, has it, in this last year?
Yeah, we never had the triage between COVID patients, but we had always the triage between COVID and others.
Okay, yeah, but, well, which is also bad, yeah. Of course. Yeah. Well, one one small comment. Well, you said, well, one of the consequences of this corona crisis was to reduce the meeting time to 15 minutes, which may be a good idea for all kinds of institutions apart from corona, because meetings tend to be too long anyway. But now a more serious question. So, and I really don't know the answer to this. So I was very surprised when some late spring, summer last year, the Robert Koch Institute announced officially masks are not needed and they may even do harm. And then a little bit later, well, they changed their opinion, and now we have FFP2 masks mandatory at least in Bavaria. And now in the newspapers today or yesterday, I read a statement that head of departments of surgery departments told the health minister that if they don't get the masks, then they will shut down their operations. And that this was then a campaign somehow to make sure that people don't take too many masks. I mean, do you know anything about this? I mean, I just don't know.
Well, the change in the recommendation was triggered by the availability of masks.
Mm-hmm.
And they decided not to recommend masks because they just hadn't enough masks for the population. And when we talk about the normal masks and the FFP2 masks, the major difference is a normal mask just protects the others. And that's the thing we normally use in the OR. We don't use FFP2 for doing surgery normally because we just want to protect the patient from small aerosols leaving the mouth while speaking. And if you want to protect yourself from getting from breathing virus in, then you need those FFP2 masks. And it was a huge battle between all institutions about those masks. And that was the problem behind that. And you said somebody wants to close down the OR if he does not get what kind of
that was the threat. I mean, I've read this in the newspaper. They said the health minister was confronted with a group of head of departments of surgery that said, well, we will close down our operations if we don't get enough masks.
But at the moment, the mask is not a problem at all.
No, and this was sometime last year, but it's still kind of an interesting development, yeah, to see an official body like the Robert Koch Institute, well, in a sense, lying to the public.
Yeah.
They could have said, well, we just don't have enough masks. Please just stay at home and let the surgeons have the masks that we have. And I think this is a big problem with trust. Now, if you now try to implement other measures, well, then people may say, well, they've lied to us before, so why should we trust them later? So I think risk communication is a big topic.
Yeah, definitely. And we started very early, just a couple of days after the whole thing began, with masks general for our whole staff, because we've seen with SARS in Asia couple of years ago that the masks work, and the people there used the mask in the street while they had SARS. And I think as long as you have the masks, you really should use them. And that this strange recommendation, it was not really good for any trust in politicians and in the institution as well.
Oh. Okay, so are there any other? Well, Klaus?
Yeah, I just have a simple question, because you talked about positive and negative PCR results. I'm just a silly engineer, so what is PCR standing for? Because in my world, PCR is a very usual term, but I'm suspecting you're meaning something different than principal component regression.
No, it's a test for the virus, where you reproduce the the RNA of the virus to be very sensitive to detect very, very low quantities. Oh, sorry, I thought it's so much in the media that I don't need to go in these details. But yeah, it's the most sensitive way to detect viruses at the moment. And it's used for the swabs from the throat and from the nose to see if somebody is infected. And the good thing is it works with such low virus load that you can detect a patient, let's say, 1 or 2 days after being infected, but about 5 days before he gets symptoms.
Okay.
That makes it so important.
Okay. What PCR, what does it stand for?
Polymerase chain reaction.
Okay. Thank you so much.
You're welcome.
Okay. Now, any other comments or questions? No. So this was really informative. Now, thank you, Markus.